Bea, whenever you say so, we go.
1 second, please. We are live. Thank you.
Thank you so much. Hello, good afternoon, good morning, buenos días. Hello? Okay. Hello, good morning, good afternoon. We're back here in Instituto Cervantes in Sydney, and we're here to talk about a thrilling topic. We've organized, thanks to collaborators that we'll see during this hour of conference on the Symposium on childhood brain cancer. It is an honor to have along with us outstanding speakers, and it is once again another collaboration, in this case with David Gallego Ortega. Mr. David Gallego Ortega is the director of the Single Cell Technology Facility, School of Biomedical Engineering, and is a colleague from the UTS University. We have been collaborating with David Gallego for a couple of years now, and it is an honor once again to organize a symposium on cancer, in this case, in a symposium on the topic of investigation of childhood brain cancer. Without further ado, I would like to give David Gallego Ortega the opportunity to give some opening remarks. David?
Thank you, Coral. Thank you very much for the introduction. And thanks again to the Instituto Cervantes in Sydney for hosting again another Australia-Spain Symposium on cancer. In this case, as you mentioned, this symposium is focused on pediatric brain cancer. And before opening the sessions, I'd like to acknowledge the Gadigal people of the Eora Nation, upon whose ancestral lands today we stand. And I would also like to pay respect to the elders past, present, and emerging, and acknowledge them as the traditional custodians of the knowledge of these lands. So we have a fantastic line of speakers today. We're going to have two types of presentations. We're going to have presentations from two different perspectives of a cancer research. Two presentations given by representatives of foundations, which whose mission is to raise funds that then they will be given to researchers in a competitive basis to enable the research in childhood cancer in this case. And then we're going to have another two presentations from researchers that are going to tell us about the latest advances and the exciting research that is coming from their laboratories. So Coral is going to be introducing each of the speakers, but I would just wanted to let you know and introduce them all in a one go. So representing the foundations, we have Dr. Jesus Sanchez, who is responsible for the research project at the Chris Contral Cancer Foundation. We also have with us Eleni Milius-Hulik, who is the CEO from the Cure Starts Now Foundation Australia. And then from the researcher part, we have Dr. Álvaro Lazaleta Atienza, who is the coordinator of the neuro-oncology unit at the Hospital Universitario Niño Jesús in Madrid. And last but not least, we also have Dr. Fátima Valdés Mora from the Children's Cancer Institute in Sydney, where she leads the Cancer Epigenetics Biology and Therapeutics group. So these are going to be our four speakers today. And without further ado, I would like to pass the stage back to Coral for introducing our first speaker, which is going to be Dr. Jesus Sanchez. Thank you very much, everybody, and welcome all the speakers and all the audience. Thank you very much.
Thank you, David. We start with Jesus Sanchez. Jesus Sanchez is responsible for scientific projects of the CRISC Foundation Against Cancer. He's a researcher, disseminator, and caricaturist of scientific comic with his Laboratoons project. He has a PhD in molecular biology from the Autonomous University in Madrid, and he will be talking about supporting and promoting the career of researchers, the path to end childhood cancer. Jesus, the floor is yours. Thank you.
Thank you. And then allow me to share the screen. Wait a second. Okay. So can you see my screen? Then, okay. So good morning, everyone. My name is Jesus Sanchez. I am the project manager at CRISC Cancer Foundation. And today we'll be talking about cancer and specifically about child cancer. So I would like to start talking a little bit about cancer. Cancer is complex. It has been with us since the very beginning of complex life. I mean, very simple animals, like even jellyfishes, can actually have cancer. So it's crucial that we know that cancer is not only a unique disease. I mean, it's the way that we use to describe when cells start behaving in abnormal ways. I mean, when they start multiplying when they shouldn't, when they go to places where they shouldn't go, or when they don't die when they must. So, and this happens when the instructions of the cells that are encoded in our genetic material are damaged or are read in abnormal ways. Errors in our genetic material can lead cells to behave in abnormal ways, and eventually it can lead even to cancer. So these errors happen in a lot of different ways and in a lot of different places in our genetic material. So cancer is not only a disease. Even people with cancer in the same organ can have very different tumors. So actually, when we talk about cancer, we must know that we are talking to different diseases even when we are talking about adult cancer and child cancer. For instance, adult cancer is very linked to age. I was talking about the errors in our genetic material. So the more our cells multiply, more alterations can get accumulated in our genetic material, and we get increased probability of developing a tumor. But in children, this is different. Cancer is associated with growing tissues. Children are undergoing explosive growth and multiplications in their tissues. And many times they actually don't need a lot of errors in genetic material to develop cancer. So it's different between adults and child. Also, in adults, there are many risk factors that are associated with cancer, like smoking, drinking, sedentarism, or obesity, can increase the risk and the chances of developing cancer. But a child develops, for example, a child that develops a tumor in a very early stage actually has not smoked or has not drank. I mean, for us researchers, it's still very difficult to find risk factors for children cancer. So adult cancer and pediatric cancer are very different entities, are very different diseases. So for years, we have been adapting adult therapies to children, but we have to develop specific strategies. And for this, we need to develop specific research in children cancer. That's why we do in CRISC Cancer Foundation. I mean, we are we know that research is absolutely vital. It's the only way if we want to beat cancer at any time. We are fully dedicated to supporting cancer research with help of our members, donors, and companies. We are a fully private foundation, and we do not get public funding. Everything is particular. Everything is society supporting cancer research through us. We are actually a very young organization. We are only 12 years old, but we are growing very fast. During these 12 years, we have invested already 14 million in cancer research. 25 of them were during the last 5 years. So we are growing, and everything that we get in, we invest in research. We are international. We are an international organization. We are based in UK. We are based in Spain, and we are based in France. So, if we want to support research in pediatric cancer or in pediatric brain cancer, we think that several strategies are needed. I will talk to you about 4 strategies that we implement. The first of it is that we think that it is very, very important to integrate research with the clinical practice. That's why we support what we call the CRIS units. They are multidisciplinary structures that we develop in public hospitals that integrate research teams that first they develop the new therapies. These therapies are then tested and in the development of clinical trials where they actually start benefiting patients. The results of these clinical trials go back to the lab. They are improved, and this cycles repeats until the therapies are approved, and then they start being used in the clinical practice. We think that this is the fastest way integrating research in the hospitals and in the clinical trials with the daily clinical practice. Is the best way to accelerate the progression of the results from the laboratory to the patient. So one of the example of this is the CRIS unit for advanced therapies in childhood cancer, which is led by Dr. Antonio Perez in the Hospital Universitario de La Paz, which is focused in all types of different cancer, but also develops projects in brain cancer like medulloblastoma or glioblastoma. They are leading experts in Spain in cell therapies. That means that they use the cells of our body, they modify them, and then they use them against the tumors. They are one of the first teams in Spain to use the revolutionary CAR-T therapies, for example. But we think also that we have to try to identify strategic research projects that have major potential of changing the clinical practice. For example, Dr. Alvaro Lasaleta, which is present here and will talk later, has a project that is supported by Chris. So it's an honor to share the screen today with him. But another example would be Dr. Chris Jones, which is based in the ICR in London, that is working in brain tumors, and it's doing major advances in determining the weak points of the different brain cancers to try to develop specific therapies against these weak points. We also think that if we want a faster advancement in science, it's necessary to create big collaborative projects. We have joined the Fight Kids Cancer Consortium, which is a joint initiative of 3 European charities that are based in France, in Belgium, and Luxembourg. And now, Chris, they have been investing 6 million during the last years, and they do open calls to develop large international projects and clinical trials that identify and target key pediatric challenges. For example, last year they were focusing on neuroblastoma and different types of child leukemia. So the idea of this is try to coordinate different multiple teams that are based in different places of Europe to try to make joint projects that have more reach and can reach better and more implementable results. And then finally, we need to train researchers in pediatric tumor research. And for this, we think that it's important to identify researchers that have potential and try to give them the tools to train and to develop their careers. For this, we have several training programs and fellowships that are listed here. For example, with the Sociedad Española de Hematología y Oncología Pediátricas in Spain, we have training fellowships for researchers to travel to international institutions to complete their training, learn new techniques, and become better scientists, and then come back and implement their new knowledge in their clinical practice. Also, we have a collaboration with the Princess Margaret Cancer Center to create a program aimed at training researchers in drug development, which is essential to try to target the weak points of the tumors. And finally, with the University of Oxford, we have launched a 3-year program to try to train medical researchers, which is a profile that is very scarce, and we have to support and train them. So together, these 4 strategies that I have listed can help us finding better treatments for childhood cancer. But for this, we need everybody. We need the support of the whole society. And cancer affects us all. So we have to push together to fight cancer. So if you want to join Chris and help us, you are very welcome. So thank you, everybody. And it was a pleasure to share here our morning and your afternoon with you.
Thank you. Thank you so much, Jesus Sanchez. Without further ado, I would like to pass to the next participant, and we would leave questions and debate as a whole and for the end. And it is an honor to have with us Mrs. Eleni Milios-Holik. She is a CEO of the Cure Starts Now Australia, which is a non-for-profit organization that funds childhood brain cancer research. Eleni founded and became president of the first Townsville Youth Chamber of Commerce and was an invited member of the Strand Redevelopment Committee, and also started the Palmer Street Merchants Association, where she served as president. As the director of the Townsville North Queensland Emerging Leader Program, she established the Bishop Mitchell Putney Fellowship in 2016 to raise funds to research into youth suicide in sport. And she is also the director of the board of directors of the Tropical Brain and Mind Foundation, which promotes the establishment of the Brain Center for North Queensland. She has worked for and supported many local charities throughout her business career, and as well as working in federal politics. She will now be talking about funding as a vital research on childhood brain cancer. Thank you so much, Eleni. The floor is yours. Can you please unmute? Thank you.
Thank you so much. The Cure Starts Now Australia is actually was founded in Australia in 2009 by a family who actually whose daughter was diagnosed with DIPG. Now, in 2009, they were told to go home and make memories. There was no cure and no treatment for childhood brain cancer. The family, or the father in particular, was unable to accept this, and so went about forming the foundation, as many families do. So a lot of foundations in Australia in particular are formed by families or started by families, which is where their core value comes from and where their strength comes from. So we are very much a family-orientated foundation. Childhood cancer, in fact, brain cancer, kills more children and adults in our country than any other type of cancer, and the statistics have not changed in 30 years. As a foundation, we are absolutely dedicated to changing those statistics. And whilst we can wait for governments and funding through governments, it's very difficult, because when you are looking for funding, it's about the biggest voice, the person with the most advocacy. So we're up against a lot, and at the end of the day, we just want our researchers like yourselves to be able to get on with research and not spend hours and hours of your precious skill set looking for money to fund your actual research. We want you doing the work, and we want to be able to pay for the work that you need to do. It's important. Foundations in Australia in particular, and I'm sure all over the world, are very, very important. They make up a large gap of where funding comes from, and we're very proud that since our inception and since our start in 2009, the Cure Starts Now Australia, which is based in North Queensland with a national reach, has funded over $5 million worth of research projects. Fundraising also becomes advocacy, and advocacy for foundations is really important. So we start advocating on behalf of our researchers, where you may not have a voice, or you may, let's say, have a conflict of interest because you're connected to an institute or a government body. We are not. So we have a lot more freedom, and we are able to fight a lot harder. We're able to speak about childhood brain cancer in areas that perhaps are unreachable by institutions, and that's in the corporate sector, in the community sector. So fundraising, to be able to fundraise for your projects, to be able to give you money for your projects, our researchers, money for our projects, becomes an advocacy. For example, we had an event on the weekend where we had over 300 people attend. It was a lunch, and whilst it was, we brought together 2 winemakers. It was a winemaker's lunch. We were able to get up and speak about childhood brain cancer, speak about our researchers. Now, the audience at that event were business people, they were lawyers, accountants, business owners, people within the community. And so many of those people had never heard of childhood brain cancer. They were unaware of the statistics and unaware of how much funding is actually funded by the government. There is a perception in our country, because we are a first world country, that the government funds a lot of research, and that's just not the case. So it's very important that we become advocates, and by fundraising, we spread that word through the people that we work within events. On Sunday, we have the largest convoy of trucks in the country, and it's called Convoy for the Cure. It's an incredible show of community spirit. We have people like Australia Post participating, FedEx participating, Ergon Energy. All businesses come from all over Australia. They bring their trucks to Townsville, and a convoy happens throughout the street, which raises an enormous amount of money, which turns into research grants. Well, we're fortunate and unfortunate in a sense that we have personal stories, being a foundation that is predominantly based in and around families, and people connect to a personal story. So as a foundation, we've had a lot of success in our fundraising because people support people. They don't support a product. So our foundation is very much about the people and the families that have been affected by childhood brain cancer. Funding and childhood brain cancer is very interesting, especially in our country, because unfortunately we have to vie for a place in a very cluttered market. So how do we make more people aware of childhood brain cancer? And whilst all cancers are really, really important, and we are very empathetic of that, and we are very mindful of that, we are also very mindful that, as I said at the beginning of my presentation, the statistics have not changed in 30 years, and that's just not good enough. So as a foundation, it is really important that we have a louder voice, that we go hand in hand with other foundations, we collaborate with other foundations in Australia, and we go to Parliament, we go to government and talk to them about what they can do. In our country, we're very blessed. There are opportunities when we can show that we have put up a certain amount of private money. The government is prepared to come in with public funding because it's a way that they're able to justify it to their constituents, let's say. So it's very important for foundations like us to be to have a bigger voice and to collaborate with other foundations, of which we are currently doing. And we have a couple of projects that we are working on with 16 other foundations, all in and around childhood brain cancer. And together we will go to Parliament at the end of this year and at the end of the sitting term, and we will discuss with our parliamentarians and our politicians about funding and the amount of funding. And we're actually looking to get a dollar for dollar match funding. So, as I said, foundations are private. We have a bigger voice. We're not constricted or restricted in any way. So we are out there and fighting for our researchers to ensure you get more public funding, but that you ensure that you also get more private funding. And that's the Cure Starts Now. That's fundraising from a very grassroots and local area. And I will say, whilst we're based in North Queensland, we have a national reach. Thank you very much.
Thank you so much. That was really enlightening. Sometimes we think things are already put into place and being managed the most efficient way, but it's incredible if statistics are still the same in after so many years. So let's do our bit and continue promoting and disseminating the need for investigation. So without further ado, I would like to continue with our agenda with Dr. Álvaro Atienza. He is an attending physician in the Pediatric and Hematology and Oncology Department and coordination of the Neuro-Oncology Unit at the Hospital Niño Jesús in Madrid, Spain. Since the year 2006, he has been an attending physician, and since 2021, section head of the Pediatric Neuro-Oncology Unit at Hospital Niño Jesús. Since the year 2020, he is consultant for the proton therapy unit of the Clínica Universidad de Navarra in Madrid, and his research interests are in the area of the pediatric brain tumors, especially in biology of the pediatric low-grade gliomas. Dr. Álvaro Atienza will be talking about oncologic viruses in the treatment of brain tumors in children and teens, adolescents. Thank you so much, Álvaro. The floor is yours.
Okay, I don't know, can you see my screen and hear me?
Yes, all good. Thank you. Yes.
Yes. Great. Yeah.
Yes, Álvaro. Yes.
Thank you very much. Good evening, Australia. Good morning, Spain. Thank you for the Instituto Cervantes for the invitation for this really exciting meeting. And I'm going to talk about the oncolytic viruses in the treatment of brain tumors in children and adolescents. So brain tumors are the second and third cause of cancer in children and adolescents, but are the first cause of mortality in cancer. The other tumors like leukemias, lymphomas have increased a lot their survival, but brain tumors still are the leading cause of mortality. So we have a few brain tumors in children that have a very, very low rate of survival. And one tumor like DIPG that has a 0 rate of survival. So we need to find new treatments in these patients. So can virus kill cancer cells? Well, we have this example from the 70s, an African 70-year-old man with a lymphoma. You see the mass in the right orbit, who had measles. And after a few weeks after infection with measles, the tumor disappeared. So this was an oncolytic virus disease that helped the patient. And we have even more recent examples, like COVID. This 62-year-old patient with Hodgkin lymphoma was recently diagnosed just before having COVID. He had pneumonia, he was very sick, And when he recovered from COVID, they saw an incredible response of the lymphoma without any chemotherapy. So yes, virus can kill cancer cells. So how does the virus or the oncolytic viral therapy works? Well, first, most oncolytic viruses are engineered to selectively lyse and replicate in cancer cells, sparing healthy cells from the adverse effect of anti-tumor treatment. So first, we need that the virus only kills tumor cells. And how does this work? Well, there are two effects. One is the direct effect from the virus to the tumor cells. And the most important effect is the immune system. So the virus and the antigens that are released with the infection makes the immune system act towards the tumor. This is why it's called immunotherapy. And this is what we are seeing that it's most interesting in this treatment. So what virus are we using in brain tumors? We are using common virus like herpes simplex virus, that was the first FDA approval for melanoma. We are using adenovirus, that it's a virus of a common flu. And this is the virus that we are using, and it has been most used in pediatric brain tumors. And then there are other viruses like poliovirus, reovirus, or the measles virus. So the problem is, how do we get the virus to the tumor? Because the brain tumors have a problem that it's the blood-brain barrier. So how do we get this virus to the tumor? So we can give systemic delivery, but if we give the virus itself intravenously, then we are going to have some barriers, because we are going to have an antiviral immune response, like when we get an infection. And also the virus is going to get trapped in the liver or with neutralizing antibodies. So this is not a good idea. The other thing is to carry the virus in cells. And there are some opportunities of carriers for this virus. And we are going to talk a little bit about mesenchymal stem cells. And then the other option is to put the virus directly into the tumor. We can do this by a stereotactic biopsy. We can do this by leaving the virus in the surgical cavity after the resection, the surgical resection. We can do this also via catheter. This is called SEED. It's a tumoral convention enhanced delivery. And we can use this catheter to give some drugs or give the virus. And also we can give it intraventricular by lumbar puncture or by an Ommaya catheter that is placed in the brain and goes to the ventricle. So I'm going to show our experience in Hospital Niño Jesús in Madrid with oncolytic virotherapy. And this was experience that has a happy initiation of the study, because when your first patient that you treat is cured, then everything goes easily, right? So we had a patient in 2008 that had metastatic neuroblastoma, and he didn't respond well to chemotherapy. So we give the Celibir, which I'm going to explain now, and he could continue his treatment with a very good remission, and now he's alive 15 years later. So it was a very initial happy research. So we use an adenovirus that it's ICOVIR-5, that it's genetically modified in the retinoblastoma gene, so only tumor cells are infected. So we put the virus in the mesenchymal cells, and we know that the mesenchymal cells, if you give them intravenously, they go to where inflammation and tumor cells are. So what we started to do was we took from the patient autologous mesenchymal cells, we incubate them in the lab. We had to grow these mesenchymal cells for 6 weeks, and then we put the virus with the cells and we gave the treatment intravenously. So we have a preclinical development with mouse, with cellular models, and we got some conclusions that the mesenchymal cells allow the replication of the virus, that we could transport the virus in the mesenchymal cells, that the repeated infusions in the animals was excellent, very safe, and we showed in the animals that the treatment made a significant decrease in the tumor growth. And what most important is that we had an immune response. So after this, we started with children, and we had a first clinical trial and some patients treated with compassionate use to show that this treatment is very well tolerated by the patients. The only toxicity that we have seen is fever, some myalgias, like when you have a flu. And this lasts only for 24, 48 hours. We didn't have any severe adverse event. So we showed some clinical benefit, and we showed that the detection of circulating adenoviruses was a biomarker for the replication in vivo. So this means that when you see if the virus is replicated in the blood, then you may have activity in the tumor. But the problem was that some patients progressed during the time needed to manufacture the product, because we needed at least 6 weeks to get prepared the treatment. We showed also some difference between the mesenchymal cells used from patients with clinical response versus patients without response. And this was basically because some of these patients were heavily pretreated with chemo, radiation, etc. So what we did was, in the next generation Celibir, and it's called Celibir because it's cells and virus. So we are using now allogeneic mesenchymal cells from healthy volunteers. This makes the process very fast because we can have the cells in 1 week to start treatment. And also these mesenchymal cells are better quality. So now we have 3 ongoing trials. We have 1 in extracranial solid tumors. We have 1, which I'm going to explain, in brain tumors. And then we have 1 in adults with metastatic uveal melanoma. So what about pediatric brain tumors? I treat children and adolescents with brain tumors, and I wanted to know really what was the effect of this virus in the brain tumor. So Javier Garcia Castro had this research with dogs that they have high-grade gliomas with a very similar schema than we are using now, with 8 weeks of treatment with Celibir and then an MRI. And this study showed really great conclusions, because we first saw that the virus went into the tumor. You can see here these areas, more brownish. This is the virus inside the tumor. And also it showed some partial responses of the tumors, and also it showed that it was safe. We also had some experience with Celibir, with autologous mesenchymal cells, like this patient that was at diagnosis 11-year-old with a high-grade glioma, a very fatal outcome disease, which we started with conventional chemotherapy, radiotherapy, and chemotherapy, but we started with the Celibir just after finishing radiotherapy. So we started giving the Celibir every week, and we gave it for 1 year, and the patient was doing well. And we gave it for another year, and the patient was going well. So we didn't want to take out the virus. So we decided to give it every 2 weeks for the 3rd year. And we finished the treatment in September 2021. And this is the last MRI in March this year. The patient is 60 years old. He's going to high school, and he's doing great. And he received 129 doses of Celibir. So this means that this is a safe treatment, and it doesn't have long-term side effects. Or another case that we treated as compassionate use, 5-year-old with ependymoma that had a disseminated relapse that also received radiation, and that we started with Celibir in May 2017. This patient received 58 doses of Celibir, showing some partial response and showing some stabilization of the disease. But I wanted to go further because I didn't know if this was the virus or was the effect of the radiation or the chemotherapy. So we decided to open a trial, and we started this trial with 2 types of patients. One, DIPG, which I said it's a fatal tumor, at newly diagnosed patients. 6 patients where we start radiation, and we start giving the virus every week for 8 weeks. We have finished the recruitment of this trial. I cannot give you results because we are still working and following the patients. And then we have another trial that it's patients with medulloblastoma with recurrence or refractory to treatment. And we only give the Celibir. we only give the allocelivir, only the virus, to see really what's the role of this virus in the treatment of these patients. Of course, I want to thank the help of the foundations. The DIPG trial was financed by El Sueño de Vicky, a foundation in Spain, and the medulloblastoma trial has been founded by Chris Foundation. This is very important because these treatments are very expensive, almost €500,000 each trial. And without the help of these foundations, it's very difficult to do this academic trial because these trials don't have the money from the pharma industry. So I can show you some interesting two cases of the medulloblastoma trial. This was a female 18-year-old patient, which was diagnosed with a localized medulloblastoma, and she had a first disseminated relapse 4 years after diagnosis. She was treated with some chemotherapies in clinical trials, and then she had, for the 5th time, a disseminated relapse. We gave, in February 2022, allocelivir. 8 weeks, you can see very mild side effects, only fever, some headache, but nothing important. And what is most important is that the MRI showed progression of the tumor after the allocelivir treatment. So we said, okay, normally with this progression, this patient would have died in 2-3 months. But what is most interesting is that after that progression, we gave more treatment. And the patient, it's true that has tumor now, but it's still alive. So we are sure that there is an immune response that is doing something to that tumor, which controls that the tumor growth is not very fast. Or like this other case, that it's an 18-year-old male that also was diagnosed with a localized medulloblastoma in 2015. He progressed in January 2018, received several chemotherapies, and then in August 2021, we recruit him in the trial with allocelivir. He received 8 doses. You can see not many side effects, only fever, some diarrhea, and the last 4 doses with no adverse events at all. We did an MRI after the treatment, and there was a significant progression, right? So as I was saying, with this tumor and this progression, this patient would have died in 2 months or 3 months at most. So the patient, and this is October 2021, when he finished the trial, is still alive with other chemotherapies, but almost 1.5 years later. So this is very interesting because we are sure that there is an immune response that is controlling the tumor. Of course, we are working on all the testing of that immune response, and we hope we have soon results. We have now recruited the 4th patient in the medulloblastoma trial, so we have still 2 more to come. So there are several clinical trials for brain tumor patients, some in children, some in adults, as you can see with the 5 virus we have talked before. And I want to highlight this trial from Marta Alonso, which is a Spanish researcher with a lot of experience in oncolytic virus. And she used another adenovirus, the DNX2401, in a clinical trial with DIPG also in 12 patients that received the tumor inoculated with a stereotactic biopsy at diagnosis. Then the patient received radiation and any treatment the investigators wanted. So she showed there is an immune response, and also she showed that that the treatment is safe, and that these patients have a little more prolonged survival than the historical course. So we have not cured yet this tumor, but this is very promising for the future. Oncolytic virus reverses the immunosuppressive tumor microenvironment and its potential in combination with immunotherapy. And this is being shown now in adults. So what are my conclusions at the future perspective? Oncolytic virus therapy is safe in children with cancer. But most clinical trials have been focused in supratentorial tumors, of course, because the most malignant brain tumor in adults is glioblastoma, GBM. So we need more trials to focus in the infratentorial tumors like DIPG or medulloblastoma. We have some challenges to come. We need to improve preclinical models because sometimes the mouse or the mice are immunosuppressive, so we cannot evaluate that immune response. We need to define biomarkers to see what patients are going to benefit from this treatment so that we can give this treatment to the real patients that are going to benefit. And of course, putting the virus in the brain with intracranial deliveries are challenging and they have an important risk of complications. So we need novel methods for viral deliveries, nanoparticles, these mesenchymal cells, and what else? We need also better response assessment tools. The MRI is not enough because sometimes we see that inflammation, we don't know if it's progression or pseudo progression. Also, the virus produces inflammation and edema in the brain. So sometimes we have to use steroids, and if we use steroids, the steroids kill the lymphocytes. So we take out that immune response. We need to better understand the tumor microenvironment and the mechanisms of resistance to the virus. And of course, as I was saying, the future trials will probably combine the virus and other types of immunotherapy, small molecule inhibitors, monoclonal antibodies, checkpoint inhibitors, radioimmunotherapy, cancer vaccines, etc. I just want to finish to thank the Pediatric Advanced Therapies Unit in my hospital that it's led by Manuel Ramirez. Also, the Pediatric Neuro-Oncology Unit that I lead with all the professionals working for the better diagnosis and treatment of pediatric of children and adolescents with brain tumors. And of course, I want to thank all the foundations that help us with this research and with the Pediatric Neuro-Oncology Unit. So thank you very much. It's a pleasure to be in this meeting.
Thank you. Thank you, Alvaro. That was incredibly interesting, really. But I would like to leave any comment or questions for the end. And now, last but not least, Dr. Fatima Valdez Mora. She has completed her PhD in molecular biology, biomedicine, and biochemistry in December 2008 at the University of Autonomous of Madrid in Spain. In the year 2009, she moved to Sydney to join Professor Susan Clark's group at the Garvan Institute to work as a junior postdoc in cancer epigenetics. And in January 2020, she joined the Children's Cancer Institute to lead the Cancer Epigenetic Biology and Therapeutics group, with a primary focus on understanding how epigenetics is altered in the pediatric cancer, particularly in the pediatric brain cancer, called diffuse intrinsic pontine glioma and DIPG. So without further ado, Fatima is going to talk about uncovering the Achilles heel of diffuse intrinsic pontine glioma to design a novel therapeutic strategies. Thank you, Fatima.
Thank you. Can you hear me? Yeah, okay. Thank you, Coral, for the introduction, and thank you, the Instituto Cervantes, for the hosting this event, especially during May, which is the month of the brain cancer, is the brain cancer awareness month. I hope this works. Okay. Well, I'm going to talk about today about a very specific type of pediatric brain cancer, which is called diffuse intrinsic pontine glioma, which Alvaro has mentioned in his talk. We call it DIPG because, as you can see, it's a very complicated name. So I'm gonna give a little bit of an introduction. Let me see if this works. Yes, perfect. Okay, so just to give you the numbers and highlight again the numbers of this terrible disease. Fortunately, it's a rare disease, but unfortunately, it has devastating outcomes. So it's basically the deadliest cancer of all. So this is a type of brain cancer that is located in the pontine of the brain, as you can see over there. The problem with this cancer is that it cannot be resected because it's located in a very critical area of the brain. So it cannot be removed. And this makes this type of brain cancer very, 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 very deadly. So basically, virtually zero survival rate for these kids. So in numbers, in Australia, every year, 20 kids are diagnosed with the IPG and 20 kids will die of this disease because unfortunately, the median survival of these kids since diagnosis is between 9 to 10 months. And they, as I mentioned, no treatments. The only option that is given to these kids is radiotherapy as a palliative for the symptoms, but really where the message that are given to the parents is like, go home and make memories because in 9 to 10 months, your child is gonna die. So it's a really, really devastating disease. I took this slide from the Levi's project, and I wanted to highlight with this that because it's a rare disease, there is not much funding from the government. So this is just to highlight the percentage of from the states, for example, that is given to research in the IPG. 4% of the government funding goes for that, which is not really much. And that's why I wanted to highlight the incredible work of the foundations like the Cure Starts Now, Chris Contra Cancer, do to enable researchers to investigate this disease. So I also took this from another foundation that is really close to my heart, Run the IPG, it's a foundation from Australia, and giving again the devastating numbers of how many kids die of this disease. So as you can imagine, what research does in this case is trying to understand the causes of the disease. And in the case of the IPG, the cause is known since 2012, is 80% of the cases, which is highly significant when we look at cancer, which is very heterogeneous. But in the case of the IPG, 80% of the cases have a single mutation in a gene that is called we call an epigenetic factor. So that's the mutation that is called H3K27M. And as I mentioned, it's an epigenetic factor. So I'm going to try to explain today what epigenetics is and to highlight how important it is to use epigenetic therapy to treat this type of cancer. This is just a summary of the paper where they published this discovery. It was groundbreaking discovery in 2012, where, as you can see, a summary of all the cases carry a mutation in the gene H3.3 or H3.1. And it's it also have secondary mutations that also help the tumors to evolve and to grow. So epigenetics is a very complex process to explain. So I have used this analogy, which I think explains really well. Hopefully explains really well what it does. So epigenetics, in terms of what it is a very important process that the cells have to kind of during development to generate the cells, the functionality of the cells. So if we use the analogy to origami, basically is that the piece of paper that we have, which has the potential to become any kind of shape, is our DNA. And epigenetics is kind of the folding instructions, as you can see here with the different steps of how you have to fold your piece of paper to make the figure that you want. So that's epigenetics, is telling the paper how we have to fold it to make a heart, so to make a cardiomyocyte cell. And that's very important during development. Epigenetics is critical and it's not bad when it's tightly regulated. What happened in cancer is that epigenetics, there is a mutation in an epigenetic factor. Imagine like the epigenetic factor that I mentioned, H3K27M, and the instructions are not well explained. So basically what happened, we have the DNA again, we have K27M, which is giving the wrong instructions, and we result, instead of having a proper brain, in this case, as a neuron oligodendrocyte that has a function for the brain function, we end up with a cancer cell, which has the capability to do really bad things. So that's what happens actually in the IPG. We have this evil K27M, which is making the cells to become cancer cells. So the good news is that not like mutations in the genome, like genetics, epigenetics can be reversed, and we use what we call epigenetic therapy, which basically what it does is rewrite the origami instructions to kind of unfold that piece of paper again, make it plain, as you can see, and redo the instructions to make the cells to become again non-cancer cells. So that's basically the approach that we're trying to achieve in our research in the IPG. So we have this, what happens with K27M, we have cells that have the proper functions to make the brain function, like neurons, oligodendrocytes, astrocytes, and so on. K27M generates this terrible cancer. So our idea is that can we re-educate these kind of cells, these origami instructions to make the cells to become non-cancerous again. So that's an approach. We're working on that and trying to understand how this happened. I'm just going to show you a piece of data that we have gotten in the lab using epigenetic therapy. These are 3 cell lines that have been derived from patients with the IPG. And when we apply this epigenetic therapy, we can see that the cells start dying. And we can see this with these bars over here, like there's less cells in the plate. So this is an in vitro experiment. And we see that in these plates, like we see the colonies, which is the formation of these cells forming tumors. When we apply the treatment, we can see that these colonies start forming. So this is our approach, and we're very happy to start seeing that in preclinical models of the IPG, this therapy is working. And this is all based on funding from the CureStars Now and Randy IPG. So we basically this would have not been possible without the support from foundations formed by families of children with the IPG. So I wanted to also talk a little bit about the journey, because I was very fortunate to actually last week attend to a symposium in the States only about the IPG, which was organized by the IPG Collaborative, which is the CureStars Now is part of it, where we meet with actually families of children with the IPG and also clinicians and research. We got all together. And it was interesting to listen to the journey of all of these families. And sometimes they're left behind, not really knowing what to do with this terrible diagnosis. So something that I wanted to highlight here is that thank you for this collaborative project, we have this kind of the IPG trial finder, which the families can go to this website and they can just type and see how many trials are currently being doing in the IPG. Fortunately, as you can see, 101 trials are at the moment active and are recruiting for the IPG. One of them was mentioned by Alvaro, the oncolytic virus he's doing, and also Marta also is doing. But I wanted to highlight this particular clinical trial that is been happening and is giving really, really amazing results. And it's all based on research that one of my collaborators and dear friend, Matt Dan, has been doing in the University of Newcastle, which they have seen amazing results combining these 2 drugs, ON201 and paxilizumab. And yeah, just wanted to highlight how important it is to fund research, and we were also here today that the research is the only way to find a cure for cancer. So I just wanted to highlight this as a clear example of the work that we do in the research lab, how it's translated to actually a clinical trial and how it's actually saving and extending the life of kids with the IPG. So this is exciting moments. I can see that with all of this awareness and work from the foundations, we are getting closer to a cure, or to at least to extend these the lives of these kids. And with that, I would just like to thank my amazing team at the Children's Cancer Institute and our collaborators who have actually helped us a lot to establish the lab and the resources. And of course, the funding bodies, the CureStars Now Australia, Randy IPG, Cure Brain Cancer Foundation, some funding from the government as well. But not least, the most important people, the children, their families, their parents. And thank you for listening.
Thank you. Thank you so much, Fatima. This has been incredibly enlightening. The goal here today is to promote, to disseminate, to give awareness, and of course, to honor the Awareness Month, May, for the research here in cancer. I must say, before we comment and give some questions, as a scientist, I am not expert at all. I must say this is incredibly enlightening for us, as the goal is to promote and to give awareness and I love the ideas to be able to gain that outreach, the origami, of course, the pictures, the experiences, and the clear language to be able to outreach, and that's incredible. We cannot forget that behind all these numbers, these statistics, these hard work of the scientists and the non-for-profits and the organizations that are here represented, there are families, there are children, their experiences, people that are here, people that are not here. We do this for them, and we do this for the research, and it has been very enlightening. We've had quite a lot of comments on wow, first time I've ever heard that a virus could cure or help cure cancer. Wow, first time I've ever seen an origami. I'll never think of origami without remembering this specific conference again. Thank you so much. So I would like to, we don't have much time. I would like to give a general question to all of you that have so generously given part of your time just here today to give just a gist of the incredibly hard work that you're all doing, each and every one of you. I would like to give a general question concerning promotion and research. As we've been talking about public funding, I can say in a general sense that there's not enough public funding. I guess part of the problem might be as well awareness. What could be general ideas that we could give out to be able to promote this need of funding, public funding, and not only for trials that can be funded by families that have actually been affected. We should all strive for research. We should all strive for funding, not only those that have been affected by these horrible statistics. What can we do? I truly think that a public funding would be a great solution, but what can we do? Any comment?
If you don't mind, I think that Eleni might have a lot of things to do with this. I think that the key is awareness. If we want public investment, but also private investment, people that actually manage the public funds are also people that need to be explained why cancer affects us all and needs research. It's our responsibility and also the responsibility of the scientists and of everyone to try to explain the importance of cancer research to everyone. Cancer affects us all, as you said very well. Not only affected people must help cancer research. Everybody of us is a potential cancer patient or has been a cancer patient. So it's key to involve society as a whole. And try to collaborate together. Public funding, private investors, general public, all together. With the help of where the public funds do not reach, we have to reach with the private funding. So I think that the key is to convince everybody that cancer is a problem that is general, transversal, and affects us all. And I give the word to Eleni because I think that she will probably add a lot of things here.
Well, I absolutely agree with you. It is about, and thank you. It is about advocacy, and as hard as it is, we have to look at it like a product and market it to people. Have to understand. When I hear from people like Alvaro and yourself, Jesus, and Far, we see the amazing work that you do as a foundation. It drives us harder to go out there and find more funding, be that public or private, whatever it is. We will continue to fight. But advocacy is a big part. I remember years and years ago when I first took the role on, I met a researcher who is very charismatic. And after a couple of glasses of wine, I'm going to be very candid because it's 6:30 at night. She said to me, you know, Eleni, they keep wanting to roll me out, and they want me to go and speak, and they want me to be like the poster person. And I sat back, and I had been watching her, and she was very animated and, as I said, charismatic. And I said, do you know what? I can understand why. She said, but I just want to cure childhood brain cancer. And I said, but there's a whole different lot of ways of doing that. What if by you going and speaking in front of a group of 500 people at an event that your institute or my foundation hosts, somebody connects and they understand? People need to meet the researchers. For me, I really push people meeting you. You are incredible human beings. You have a God-given talent, but at the same time, you have to come out from the labs. People have to meet and see you. And when they see you, so I said to this particular person, and a few of you know her, what if you don't cure childhood brain cancer in the lab? What if it's because you speak at an event that I host that might be a change-making event where I am able to bring philanthropists together who actually want to invest their money into childhood brain cancer research. They meet you, they like you, they get you, and they recognize you, and they go, okay, I see it. They have to see it. The greater public have to see it. Our statistics are not good enough. And when I sit in on a meeting like this, which is incredible, and I thank everybody for taking their time. I can't imagine where you've come out of to be here today. It makes me want to work harder because your research is showing traction, and I know that we're close. I know that we're not far off. So we can only do it with more funding because, as Alvaro said, these trials are very expensive. And there shouldn't be a price on the life of a child. So that's me.
Yeah, I want to add 2 comments only. Of course, it's all about awareness and it's all about funding, but I think it's also about making the researchers' life easier, because all over the world, the researchers have to live with grants. They are all year asking for grants, and that's what makes them the salary. Well, I mean, clinicians have a salary, so researchers have to have a salary. And then, of course, they will apply for grants for the projects. But I think we have to make the researchers' life easier. And also the clinicians like me that want to do research, we need protected time because we have to see the patients, and it's impossible to have patients and research. So we have also to try to incentivize the clinicians that want to do research, because the most important thing in research is from the lab to the kids, right? So this is an important point also to improve this this investigation and this research and improve outcomes in the future.
I just wanted to join and say I totally agree with everyone's comments. Awareness is so important, and in particular in pediatric cancer, I think people tend to think, and I mean we see it with the global statistics, pediatric brain cancer has changed in terms of overall survival from being 50% overall survival to 85%, but it's because there has been huge advances in leukemia. But if you look at its different type of tumor, you'll see that the DIPG pediatric brain tumors are doing really bad, and they haven't improved in the outcomes for 40 years. So I think we do have to make that very clear, like the awareness is key to make people understand how important it is to invest money on these 20 kids in Australia, 300 kids in the States. I actually don't have the numbers in Spain, but I believe it's about 50 kids per year. So I think it's important that make people realize that this is still a lot of work to do in pediatric brain cancer. And at the moment, because it's a rare cancer, it doesn't happen in many kids, the government doesn't seem like it's overall important to invest. So we have to make them realize that it is important. And as Eleni was saying, there's no price for the life of a kid. You don't have to put up that.
Thank you. Thank you so much, Fatima. I would like to add a comment that has been sent online. I would like to thank the organizers and speakers on behalf of our research group. It has been very interesting for us. We belong to the group of Professor Marin Lab, ModCell, at the University of León from Spain. We are working with the brain organoids and trying to establish a platform to use as a model of brain tumors, especially glioblastoma. Our time is almost up. I would not want to close this symposium without thanking you all truly from the bottom of my heart for your time. Today it's an hour, but this will go on and on thanks to social media. Our job here from Instituto Cervantes in Sydney is to promote research in Spanish, to promote Spanish researchers, to promote research in general. I truly am honored to have you here with us online, face to face. It is May, as we said before, the awareness month for cancer. It is great to have not only you as researchers, but also non-for-profits and organizations that you represent. It is not only, as Eleni said, that people that can actually help with funding get you, but it's also truly important for them to understand you. For that, this is so important, what we're doing here to promote, to give information on what needs to be done, not only statistics, which are, by the way, astonishing, that statistics haven't been better in the last in the last 30 to 40 years, but it's also enlightening to know so much can be done by research. I would like to finish by saying something that has been said before. This is not mine, but it is a truth that must be underlined. Research is the only way to cure cancer. This is our first step, a small stepping stone from Instituto Cervantes. We are not scientists here, but I can say that I have understood a lot here. First time, by the way, and as I said before, just as a joke, I will never think of origami on the same way. Thank you so much for your time. We are here to help. We are here to promote and to disseminate this this symposium, which will be on our social media and of all of the people here. Jesus Sanchez, Eleni, Álvaro, Fatima, David, and all the equipo Instituto Cervantes of Sydney. Thank you so much for your time. It has been a privilege and it has been an honor to be here with you. Thank you.
Thank you, everyone.
Thank you very much.
Thank you.